Okay. All right. Welcome, everybody. We have here July 29th, and we really appreciate everyone joining us for this next installation. And today we're going to be talking about a topic that is near and dear to our hearts here in Florida. And hopefully it's near and dear to what you do in your part of the world. But the state of Florida for many years has gone through a transformation, I would say. And the talk today is going to describe how we've really transformed our entire state from a state of just siloed agencies performing CPR on patients who go to random hospitals, who get a random outcome, and nobody gets any better because of it. What we're going to hopefully show today, and I know this is being done across the country as well, is that if you start with data collection and then you move towards education and you move towards collaboration, meaning bringing in the 911 centers, bringing in the hospitals, and then all along following those outcome data, then ultimately you could start to see a noticeable difference in the outcomes that you have in your state. And what we're going to start with is to actually look at the data. We're going to challenge you today to say, do you know your own data, meaning your own agency's data? Do you know the data from the hospital that you transport to? Do you know the data from your state? And then how does that compare to other states? How do you compare it to other EMS systems? And I will tell you that as far as I travel around this country and I ask people for the data and their outcomes, most people scratch their head and they say, yeah, we're pretty good. We have a big team here of just great guests today who have made this their lifelong mission. And I'm going to go around real quick around the horn and start with some introduction. So if I can, let's start with you, Dr. Carrie Batista, up from the northeast aspect of Florida in the St. John County region. So Carrie, can you make an introduction?
I'm Dr. Carrie Batista. I'm the medical director for St. John's County Fire Rescue. And I'm also an assistant professor of emergency medicine from Mayo Clinic, Jacksonville. And I guess I'm the chair of the Florida Resuscitation Committee for this program.
Excellent. And you're going to hear great things from Carrie, who really spearheaded this program. Let's go to Dr. Ben Abo. Many of you know Ben. We always say, where in the world is Ben Abo today? And so Ben, thanks for joining us today. And if you can give everyone a little bit of background on you.
Absolute pleasure. I am Ben Abo. I'm an EMS physician, of course, in Florida. I have a number of ALS non-transport services around Southwest Florida, as well as the city of Gainesville, and I'm the medical director for Escambia County Public Safety. And I'm was the president of FAMSMD when we took on to, take things from the group and continue to push for these Florida Resuscitation Centers of Excellence.
And excellent. And just to expand on FAEMSMD, which Ben just alluded to, I'm going to move now to Melissa Cahey. Melissa has been a stalwart. She's been our backbone at the state, at the EMLRC and the FAEMSMD. So Melissa Cahey, thank you for joining, and please give your introduction.
Hi, everyone, and thank you, Dr. Handtevy. I am Melissa Cahey. I'm the Executive Director of the Florida Association of EMS Medical Directors. FAEMSMD is providing project management and administrative support for the FRCE and Resuscitate Florida, and I'm really excited to be here today. Thank you.
Excellent. All right. Thank you so much, Melissa. And we have some other guests that will be coming on towards the end. Unfortunately, we had one important guest who couldn't be here today. Why? Because he's actually at a ceremony currently where an HCA hospital in Key Largo is becoming, or in Largo, Florida, is becoming a resuscitation center of excellence. And he's at the ceremony. We try to have him live stream in, but apparently that didn't work. So hopefully Tom DiBernardo will join us. So I'm going to start off by talking about what is Resuscitate Florida? Where did this concept come from? And if I'm being honest, you see that Chief Dan Moran's on this call today, who's now my partner in crime. And Dan and I worked at Davie Fire Rescue for many years together. And many years ago, Dan was able to, with the help of Chief Gonzalez, bring in, this concept of the Resuscitation Academy to the state of Florida. But we wanted to build on that and say, beyond just high performance CPR, which is that middle pillar, what else can this umbrella hold underneath it? And now currently what we have, thanks to people like Carrie and Melissa, and especially Tom DiBernardo, we've created this kind of like, three-legged stool, if you will, of Resuscitate Florida. It's telecommunicator CPR, which we've been teaching for a long time, but now it's a standardized course that all telecommunicators in the state go through. High performance CPR, that's what you know as the Resuscitation Academy, and we've been doing that for many years. And now this new thing we'll talk about today is the FRCE, Florida Resuscitation Centers of Excellence. And that's what we're going to take a deep dive into here in just a minute. Now, we started it with CARES. The only way that you can enact change in healthcare is to show people that something is not working. And so I urge everyone on the call today, if you don't know what your overall outcomes are, if you don't know what your Utstein survival is, if you don't know what your neuro intact survival is, you can make one phone call or send one email and you can get it. And that's so important, and I'll show you why here in a minute. But basically, when you have CARES, it brings, the 911 center, EMS, and hospitals together because those are all interdependent on each other for that big outcome. And you can also look at outcomes without worrying about PHI and HIPAA and all that kind of stuff. So I have a big picture of Tom on the call here. Former fire chief, he tried to retire. We then gave him an office, and then the state pulled him away. And now he's the person who got CARES up and running at the state, Resuscitate Florida up and running at the state, and now we're working on some other very big projects at the state. So Tom is an incredible human being. As far as CARES is concerned, every year CARES puts out all of their data. But if you have access with a username and password, you have access to your own data today, every day. You can go in every single day and check it. I usually go check it once a quarter. Their 2024 data was released. So I do want to just take you through 3 minutes of good CARES data overview so you understand what type of data they're looking at. If you want to know how to get there, just look up this website, mycares.net, and then you go to data, and when you go to reports, this is the 2023 annual report, but then they have the 2024 report, which is now out, and that's what you need to look at. I'll show you that here. What's interesting about CARES is that they actually start to compare states, and you can see that the state of Washington versus the state of Vermont has a significant difference in outcomes, right? The national average is right around 10% for overall survival, and you can see that there's big swings either way, and that may beg the question why. Now, you may say, well, maybe in the state of Washington, they have fewer arrests, the types of arrests are different, but at the end of the day, you're going to see 20% of your cases will be VF, the other 80% are going to be PEA, asystole, and everything should kind of shake out this, pretty much the same. And the only differences are at that point, the 911 system, your EMS system, and your hospital system. These swings are based on one of those three things. And obviously the bystander CPR rate would be nice too.
Huh?
Gordon there, okay. So now let's take a look at CARES 2024. What was interesting is that when you look at the pediatric data and you look at survival, it's the lowest you'll ever see because these are the kids who are the 7 a.m. code, parents slept on them, what have you. So you'll see more infants than any other age group, and that's going to be the lowest survival. When you get to the pediatrics, 1 to 12, you can see fewer cases, but the neurointact survival goes up. And then when you put those two together, which I don't think you should lump these two groups together, but if you do, you get to a 7.6, fine. But then I want you to see the teens. The teens are the smallest number of cases. This is around the country. but you can see the highest neurointact survival. Why? Because these are the VF cases. How does that help you in your own system? Well, when you're going to a teenager, be prepared for the VF case. When you're going to the newborn, be prepared for an asystole PEA that may have lividity and may have rigor and may have a lower outcome, but those would be the most common cases you would see. In the adults, obviously, this is the bulk, 136,000 with a neurointact survival of 8.2%. Remember this number because it's very simple to get the math here. All you got to do is you should have a whiteboard in your agency of every person who walking and talking after you resuscitated them, right? That's a number. If you have a population of 100,000 people, you may have 6 or 7 or 8 if you're lucky. You take that number 8, you divide it by the total number of arrests you ran that year, and that's your number. That should be your benchmark. If you can get to double-digit neurointact survival, right? Call me. I will send you something. I'll send you some Handtevy swag, right? Now, obviously, that wouldn't be just on 1 or 2 cases. You know, you're probably going to, depending on where you live, you'll have anywhere from 12 to 80 to 600 to Palm Beach County 800. Getting to above double digits, that should be your goal. So if I put all those together, you could start to formulate a picture now and start to understand what your survival numbers should be like at your agency. And that's what we're going to get to here soon. What I want to show you here is, this is a pretty kind of dramatic slide, if you will, because you start to call BS when people say the kids are harder to get back to life. No, they're not. No, they're not. The infants are, and that's why people kind of bucket them differently. But the 1 to 12-year-olds and the teenagers, you have a higher chance of survival, CPC 1 or 2, than adults. Okay, so let's break the myth of that. You know, kids are more resilient. They're younger. Their DNA is better. Their genes are better. The mitochondria are stronger. We should be getting those kids back, especially after the infant age. And then when you look at the shockable rhythms, you can see that the teens have the highest percentage of shockable rhythms, and therefore they have the highest survival rate. It's all good, very good information for your training. It's good information when you're en route to the call and those types of things. So before I pass it over and introduce Dr. Batista again, how does this help in Florida? Well, very simple. I just take that chart and then I take my own agencies and I say, okay, because I can get all the data I just showed you, I can get it on an agency level. Survival to discharge, neurointact survival. We didn't talk about Utstein, but we can talk about your witness shockable survival. And then you graph it compared to everybody else. And that's where you go in and say, folks, either we're doing great, keep doing what you're doing, or you say, folks, we have to do TCPR. We have to do high-performance CPR. We have to go talk to our hospitals. The trifecta of Resuscitate Florida all blends into to these numbers that you're seeing here. So with that being said, I want to pass it now over to Dr. Kerry Batista. So he's very humble. He's very modest. He's kind of like silent but deadly kind of guy. He's a no-nonsense medical director. He's the medics medical director. And he is someone who said, well, why aren't we doing better? So Kerry, please come on in and let us know, how did this whole crazy thing start with the Resuscitation Centers of Excellence?
So it goes back to 2019. Myself and a few other EMS medical directors were talking about, you know, what's out there in cardiac arrest and just sort of some cutting edge things. And a side conversation was had, well, what's going on in the state of Florida with cardiac arrest? One of the people on the call happened to know someone at the University of Miami in the cardiology department and said, you know, we should all get together and discuss just a day of what's going on in Florida with cardiac arrest in regards to EMS and the hospitals. And so we just had this impromptu, almost conference day, where we had, each one of us sort of talked a little bit about something about what we're doing with cardiac arrest, cardiology, and some cardiologists were presenting. There was some people that presented on some socioeconomic issues that were going on. And we got a couple of things towards the end of the day that we figured out. One, that there's a wide disparity in the care that's offered throughout the state. We have a state that has very urban and suburban and compact areas, and then we have some very rural areas. And so there's a wide disparity in the actual care and in the outcomes. Number two, that a lot of these high performance EMS agencies are getting pulses back on a lot more people. It used to be EMS used to work a code, and then you're bringing the patient into the ER, and then, invariably probably didn't have a pulse by the time they got there. But that's not the case. I mean, 30, 40, 50% ROSC rates are becoming standard in a lot of these high performing EMS systems. And then a lot of us that are medical directors for systems, we know we all have anecdotal stories of patients that got care that was a little different than it probably should have been at the hospital. We have anecdotal stories of this pathway and that pathway happening in the hospitals. But as a system medical director, we all kind of knew what hospitals had a little bit better outcomes than others, what hospitals were doing. And one of the people at the meeting, I believe it was Dr. Shepke, said, I heard these resuscitation centers was floated in another state, and they just sort of recognized just a basic resuscitation center. And that kind of ended the day. It ended on that. And then we had a little something called COVID, and the world ended, and everything stopped. And it stopped for about 2 years. And then, I was sitting around one day, and I emailed the group, and I that was there, and I said, "Hey, remember we had this talk? Let's revisit this. Let's get a group together, and let's talk about what this would look like, what this is, how we can implement this as a process of improvement for basically the state. We can cover this. We're all, as an EMS system, we're working on the things that we can do. How do we take that next step? Because it always amazed me that, we're doing all this stuff in EMS to try and get these patients back. And then the outcome we're looking at is way down here with all of this stuff in the middle. So how do we optimize the entire system? And we had a group of medical directors, probably about 8 to 10 people, medical directors, cardiologists. It was a lot of ER doctors. Most of us are ER physicians as well. And we sat down and looked at this, and the process we looked at is we started at arrival. So let's take the patient that arrives post cardiac arrest with a pulse, and let's look at each step that person moves through, and what are the touch points, and is there some evidence? Can we provide a framework to this? Can we provide a metric to this? And just sort of build off of the previously successful models that are out there for stroke centers, for trauma centers. You look at metrics out there that are like sepsis protocols and things like that. Sort of what can we do to sort of build off of that?
All right. Well, and then so that ended up taking you to a point where you had criteria put together for primary and comprehensive, which we're going to get to here shortly. But before I pass it over to Dr. Abo, I just want to say that all it takes is one person to care enough to get people together, to inspire people, and we're very grateful that you did that, because it's really changed the game here in the state. So thank you so much, Dr. Batista, for that and for that history. So let me pass it over to our good friend, Dr. Abo. So Ben, you, as the president of our state association, Florida Association of EMS Medical Directors, you said, I want to take this and, really expand upon it and get everybody on board. So if you want to go ahead and take us through the Resuscitation Centers of Excellence, and then we'll go through the criteria more in detail when you get to that point.
Yeah. So, it was wonderful thinking. And I hail from, like you, from Pittsburgh, where we already had, there's an example, some regionalization where post cardiac arrest care, they had a, neurointensivist, cardiointensivist, emergency resuscitation, and they would try to kind of regionalize and get those cardiac arrest survivors there. And when this meeting and this information was broached to me when I was president of FAMSMD, I'm like, yes, this is a perfect place for us to house this. Debo had brought it up, and this is our wheelhouse of emergency physicians and especially EMS physicians and the medical directors, right? And so the overall purpose of bringing it all together was to help go along with the excellent work that was being done with the TCPR and Resuscitate Florida, to how can we further facilitate this whole resuscitation system of care? And that's, we've all been in different areas. I just recently moved up to the Panhandle for a substantial amount of my time. And with different health systems, and everything's just very different where they're doing stuff. Heck, I wouldn't be surprised if some places I walk in and they're still stacking shots like when I first became a paramedic 25 years ago, right? So it's evidence-based everything. It's education, community, for cardiac risk reduction. It's just really everything from drop to discharge, but actually earlier than the drop and after the discharge, right? So it's just really everything, and also creating this like support network for survivors, the families, also resuscitationologists, right? So there are, see if that goes to the next slide there.
Yeah, I got you.
Did awesome. So this is in the slide deck from when we're presenting the different stuff. And I did want to point out, I love this metaphor in terms of when you're doing a puzzle, you usually start off with those corner pieces. Those corner pieces are true leaders. This is people like Dr. Handtevy, Dr. Shepke, Dr. Batista, who saw a problem, really wanted to work it through, and came up with an idea for a solution. How can we do better? How can we get meaningful resuscitations to increase? Because if you look at our numbers, our ROS rates went up above the national average, increasing in the last 23, 24. But the neuro, like that wasn't exactly the same. So those are those corner pieces, like I said, Dr. Batista. But they can't do it alone. And so after you find those corner pieces in a puzzle, you do the rest of the border, right? So you fill it in. And these are other leaders. This is exactly like a lot of the people on this call who are taking this idea and figuring out how can we do this in our selective areas. Now, whether you're an EMS chief, a paramedic, a Proby EMT, I saw sign on here, you're important also, educators, custodial services, everything, right? So we fill that all in, but the picture isn't there. And so everyone comes in different shapes and sizes, and we all have different roles. Some, you could say, well, I'm the only important one, or I'm not important. I just can't do without everyone. The point is, we're different shapes and sizes, and we all have a role. So we put that beautiful picture of the best resuscitative care ever with our goal for Resuscitate Florida, which is to see another sunrise. You go to the next slide there. This is where I was talking about our ROS rates versus for Florida versus the national average and the neuro outcomes. Again, we want meaningful outcomes. You can go to the next slide. As I mentioned, there are different efforts around the world doing different types of things, starting with even CARES being international. Really, it's our national stuff, but there's, equivalents and stuff around. A lot of things being done in different places. And if you go to the next slide.
So actually, Ben, before we go to the next slide, I'm always fascinated by, I was on Twitter one day and I was putting up our numbers, and some guy from the Netherlands, like, starts throwing me down. Basically, he's like, you guys are horrible. 8%, we're at 24% neurointact survival. And the reason I bring that up is because the biggest difference is that they get early bystander CPR, they get AEDs to everybody in the pre-hospital setting, and they have their EMS all set up, and they have their hospital set up. So it's not like they're doing magical CPR. They're just doing everything better. And that's kind of what you're alluding to, isn't it?
Exactly. They're already pre-set up, so to speak, with that systematic bundle of care for pure resuscitation, and everyone's looped in together, hand in hand, and they're not siloed as you had mentioned, right? So we came up everyone with this, the two levels, and this is where we're at right now: primary versus the comprehensive center of excellence. Right. So for to be a primary, and I welcome as I go through this for anyone to have any questions for Dr. Baptiste or Handtevy to jump in. But overall, to become a primary resuscitation center of excellence, you're using a bundled care approach with defined order sets, standard nursing orders, structured documentation so we can look and compare things and have the proper handoff, and the ability to implement multidisciplinary care plans. And I'll talk about, some what our first comprehensive center of excellence did, even, involving nutrition and all. There's the outreach program to community organizations for health and lifestyle modifications so that hopefully we can decrease the prevalence. There is, and this has been an interesting topic in terms of having evidence-based protocols for termination of ED resuscitation efforts. That includes not just length of time for resuscitated efforts, but some sort of physiological parameters like end tidal, potassium or labs or something like that, ultrasound, having something with it to be able to help decide, hey, is this futile? Is this not? So we have justice of care. And one of the biggest things for me is the hospitals and all the disciplines within the hospital providing active feedback to EMS agencies. And that starts with being registered and part of CARES.
Okay, so let's pause on that for a minute.
Beautiful.
Hospital to be part of CARES, they have to sign the forms, the legal forms that CARES provides nationally, and then they have to give, I think it's like maybe 5 data points. It's some small number of data points. Basically, we want to know, how did Mr. Jones do? Can you expand on those? Like, what are we really asking the hospital when we say we want you to be a part of CARES?
Peter, I'll handle that. CARES is very simple for the hospitals. When the data is entered and the cardiac arrest is entered into CARES from the EMS side, and the EMS side, it enters all of the stuff generally automatically into CARES as sort of, it's called a folder of this patient and what they got in the field. And then this patient was sent to Hospital A. Hospital A will then get an email from the CARES website that basically says you have a new CARES patient for outcome. You open it up, tells you the patient, you look at the patient's outcome, and there's 5 questions. It's things like, did the patient die in the ED? Did they go to the cath lab? Were they cooled, or some sort of target temperature management? And most importantly, for what everybody's looking at is, what was that patient's outcome if they were discharged? What was their CPC score? And so it's very simple. It's like 5 questions that the hospital has to answer. It's all HIPAA compliant. It is a national database. It is all NIH funded, HIPAA compliant.
Why would a hospital not want to do that?
That's a good question.
That is a wonderful question, and I can't think of a good reason.
Especially when...
Come on, Ben. Yeah, yes, you can. Yes, you can. The reason has nothing to do with anything except that they don't want to look bad, right? Because true or false, the hospital is required to let the EMS system know what their CARES outcomes are.
Yeah, the hospital should have feedback to that EMS system to let them know what there is.
No, I didn't. No, that's not what I meant. I meant that Hospital A gets inbound from 5, 6 EMS systems. They see 100 patients that year that had ROSC. How many of those patients left the hospital CPC 1? Do they have to share that data?
Without being part of this, no, they don't have to share or tell anything. But that's why I like this. It's feeding back in so that they do have to have that discussion so we can follow up and see what's working, what's not.
My
And if you
point, though,
draw
Ben, is-
if you draw a parallel to these hospitals, they talk look at the stroke data. They submit so many more data points to any of the stroke registries, and they're all doing that. They're all showing those outcomes, and that's how stroke care is improving. And this is really there's really only one reason why a hospital would really not want to participate.
right. So basically, I think that the bottom line here is that when you go to the hospital and say, "Can you please show me your CARES data?" If they say to you, "No," that's a red flag. If they say, "We don't want to participate," that's a red flag. So hopefully you have hospitals who say, "Yes, we know what our CARES data is. We know how it compares to the national average. We see we have some work to do," right? So now moving on to this aspect, Ben, just so everyone in the audience understands, when a hospital, when Ben Abo comes to a hospital and says, "Hospital, I want you to be a primary resuscitation center," you're effectively saying you have to be part of CARES, but you're also saying that you need to do all these things in order for me to bring you patients, aren't you? That's the key here.
So the
Absolutely. Yep.
the goal of this is to develop a system of care, right? If you're a medical director for a system, you know where your comprehensive stroke centers are, you know where your primary stroke centers are, and you build a protocol to deliver the right patient to the right place. EMS should not be just take the patient to a hospital. It's take the right patient to the right hospital. And so you build a protocol which drives those patients to where they need to be. And we do it for stroke, we do it for trauma, we do it for STEMIs. And through this program, we could also start to look at what are the availabilities in our systems, and allows us to develop that system of care for the patient's best interest.
Perfect. So is there anything
Absolutely.
about the primary resuscitation center that we want to explore here, or because it's a little vague on this form as what the hospital needs to do. So is it possible to expand that the hospital has to do this bundle, these order sets, they have to interact with the community, they can't just terminate early, they have to have prognostication that aligns with what people are doing across the country, and
So
they have to participate with CARES.
Go to the next slide.
Yeah, if you would.
So, all right, go back to the primary. So we'll go back to primary for a second. So if you look at it, so we start at the beginning, and there's a whole attestation letter, and it starts at the top, and it basically sets up a framework and metrics for the patient as they move through the system. So if you look at the first thing, bundle of care approach. So we're looking to bundle the stuff. And if you look at sepsis guidelines and things, it's all a bundle of care, right? You see a patient in the ER, you hit sepsis, you get this bundle that pops up with all the things that you need. And we're looking for something similar of that. Then the next step is, do they make it past the ER? And so we know that time isn't as important, because as we do more aggressive things with cardiac arrest, there are patients that go a prolonged period of time. I have a guy in my system, 72 minutes last year. He was in cardiac arrest, and he's a CPC1. So it's more than just time. So pick an objective criteria. We just want to have something that's objective there. And then it moves on. So every patient with sustained ROSC should get a cardiology consultation. That consultation, if you look at the framework that the program builds, we're not going to dictate exact things of care. We're going to say that a patient with sustained ROSC, a conversation should be had with cardiology. They should know the patient is there. The spirit of this is to get an entire team approach for these patients. Bring the entire team to the ability to get that patient better. So cardiology needs to know about a patient that had a cardiac arrest and is being brought into the hospital. And that conversation may just be, I'll give you two examples. That patient may be, a hospice patient, PEA arrest, non-STEMI on the EKG. Great. Nothing really to do there. Nothing that, no balloon pump, no cath lab, nothing like that. This patient is a 50-year-old at the gym who just had a VFib arrest and now has a STEMI. Well, there's a lot for cardiology to do. So cardiology gets a touch point there. Hey, this is coming in. You know about this now too. And then target temperature management, hypothermia, normothermia. Most hospitals doing normothermia. It's whatever it is. And then it moves on to in the ICU, daily EEG monitoring, no neuroprognostication for 72 hours. A lot of evidence-based sort of things that most PC, and the goal is that if you're a PCI capable hospital, you should probably reach the criteria to be a primary resuscitation center. And then it moves through with other things, nutrition, spiritual care, some educational things move through there, basically to bring a multidisciplinary approach to follow that patient through the hospital.
And let me expand to, as Dr. Bachista just said, about the neuro prognostication and stuff. The reason for this is, we're not dictating what you do, but it's having an evidence-based team approach. There's still a lot of places that are like, well, you just got ROSC, pupils are fixed and dilated, probably not going to make it because stats overall stink. And then that's it. And they don't decide whether they're going to do something or not, or do further evaluation. And so it's kind of forcing the hand to be like, hey, let's make sure we're doing the right thing based on evidence for that multidisciplinary approach. And not just because of what we learned back in the day and this and that, we're going to say, well, I'm not going to really consult this because I don't think they would want to hear. It brings everyone to the table so we all could have some input with that. And the points on this slide is the kind of a bridge. It does come up again on another slide that kind of expands it, but I think I saw Dr. Handtevy put the list to the attestation, further expanded beyond these points. But again,
for you guys. So
yeah.
Ben and Terry, so a hospital says they're going to do these things. Is there a requirement for quarterly meetings? There being resuscitation meetings that we can, almost like we do for trauma at the T-Quick meetings, etc. Can you expand on the fact of, once you get this rolling at a hospital, what are the checks and balances, if you will, that these are happening effectively?
So I think a couple of things on that. Number one, I wrote a couple of notes here to bring up to bolster that. Number one, just about everything on the list should not cost anything. There's not really much of an additional cost. Most of them are metrics. Mm-hmm. It's identifying people to sort of lead the effort. Have a resuscitation center medical director. Something you have to hire. That's your ED medical director. That's your critical care medical director. That's somebody who's going to sort of champion the effort. And it makes that group in the hospital, because really what this is metrics that you're going to be able to look at. Because one of the things that we've heard from hospitals that, we do all this stuff, one of the things we've heard from them is that, yeah, we do all these things, but we didn't realize that we could do them better, or we could look at this better. And really nobody's reviewing these cases and seeing how they go. So by having those personnel identified, by having those metrics that you can look at, then you could say, hey, look at these cases, and then maybe change pattern, kind of bring the whole hospital up to a new level. And that falls out to regionally as well. Part of this is, and the reason why it's not really a top-down thing, it's just a framework, because we want the hospitals to work on this. Because hospital A may go, hey, we do this, and this is working really well. And then hospital B says, oh, we're going to do that too. And just sort of feed into each other. So eventually there should be regional collaboration on this going forward, to sort of drive the thing. And my hope would be that Florida becomes sort of the resuscitation center of the country. If we're doing aggressive things, these hospitals that are working this framework and doing these things, they're going to come up with ideas, and they're going to push the system further than we ever could.
Amen. Amen to that. All right. Well, for the sake of time, let's go, Ben, to the comprehensive side of the house. So The comprehensive, you can explain how does it relate to the primary and what are some of the additional requirements here?
So you hit all the requirements for the primary resuscitation center. And then on top of that, you have neurological critical care, neurocrit care, monitoring with some sort of neurointensivist consultation services. There's established research and advancement of cardiac arrest care. That could be anything. It's just trying to help promote this. In-house mechanical CPR, eCPR, or mechanical circulatory support capabilities. There have been a couple of questions. This is an in-house 24/7 availability, not just on call and 30 minutes in.
To clarify, you're talking that it's 24/7 ECMO.
24/7 ECMO, yes.
Thank you. Okay, good.
And that's in-house, not services called in.
Yep.
EMS collaboration to develop an aggressive and progressive system of care. And again, this goes with the even further expanding upon the community support efforts, bystander CPR, TCPR, and stuff like that. The in-house 24/7 pulmonary critical care and on-call and interventional, and a comprehensive medical program focus on primary prevention, which was kind of already discussed. And with all of this, I'd say what Dr. Handtevy was just asking about too, like when you sign this attestation, it's the heads of the hospital saying we attest that we fulfill these requirements. There's also places for the local EMS, whether it's fire-based or not, to kind of say in this also. And so for me, this is my way of saying, we are going to have regular meetings so we can see what we're doing. What can I do better to help the hospital? What can the hospital do better to help the people, et cetera? So that's where I can kind of force the hand to have those meetings and have the talking together. And all these ways to meet the attestation criteria, whether it's primary or comprehensive, you can come up with within your own ways, whether it's the hospital or EMS or both together coming up. And then all this feeds back to giving other hospitals and health systems different ideas. What can we do? How can we do it differently? How can we do it better?
And I think it's safe to say, at least for me, and I think for everyone in the room here today, that if you're a medical director, if you're an EMS leader, and you're not having at least quarterly intervention or interaction with your hospitals, then that's probably got to change in general. But what you're saying here, Ben, is that we're going to have quarterly meetings or regular meetings with respect to how we resuscitate, what our outcomes are we doing eCPR, what does that look like, etc. Right? It's not just that you saw them and said hello and that checks off the box.
Exactly. This is specifically getting together, me probably always over food or coffee, but getting together and let's specifically talk about this. How can we make God's Waiting Room, Florida, the center for, Center of Excellence for Resuscitation?
Perfect. Okay, excellent. So this is a perfect time to bring in Dr. Eric Bassan, who is in the image there. He's front and center. And maybe I'll have Melissa come in real quick and talk about Memorial Regional Hospital. That's where I was born. That's where I worked for 20 years. Became the first ever in the state comprehensive center. Melissa, can you just say a couple of words, and then I'd like to have Dr. Bassan and if Dr. Castro is here as well, talk about what it has been to be the first FRCE in the state. Melissa, you want to give a couple of words on the steps Memorial Hospital took to become the...
Yeah, sure. Hi, I'm sorry. I thought there was maybe another Melissa. So, and we've learned a lot over the last couple months as this program has really taken off, as they mentioned, posts and pauses with COVID and things like that. And Memorial being the first really taught us a lot of things too that we needed to do in terms of managing the process flow, data and information and things like that. So we do have a process that we've set up where we're having folks or hospitals submit an interest form online. Then they go to our website and they're able to find our toolkit and a plethora of information and resources, including what Dr. Abo and Dr. Batista have covered today. I will say that when you are starting something like this in your state, you definitely want to make sure that you have the processes in place, website and tools and resources, and then a marketing plan. Once we started marketing and increasing the awareness around the state, the momentum and interest in the program has been remarkable.
All right, excellent. And so that's a great segue for Dr. Bassan. So Eric, thanks for joining us today. You have led the charge at Memorial. So it's a very large tertiary care hospital. It's where everything comes towards Memorial. If you could describe what this process has been like and how it's impacted Memorial Regional Hospital.
Sure. Thank you, Dr. Handtevy, Melissa, Dr. Abo, and everyone involved. This has been an excellent experience. We first got wind of the Resuscitation Center of Excellence program, I would say probably mid 2023 to late 2024. I would get like PDFs of the intermittent updates to the criteria that have been going on from each committee meeting. And then finally, we received, we had a big push from our, actually the CEO of the hospital, wanting to make us the first comprehensive resuscitation center of excellence. So what we realized is that, like you had mentioned, most of these things we were already doing. We looked at all of the criteria and tried to hit on some of the points that we were lacking, for example, the community outreach or making sure that our targeted temperature management numbers were up to par for the criteria that you guys have. And also we had already been doing these meetings. We were actually at that point doing monthly resuscitation meetings, reviewing every single out of hospital cardiac arrest case. Now, in line with the criteria, now we're doing these quarterly meetings. But what we found was that there was a lot of enthusiasm within our system and in our hospital to actually become a center of excellence. And we were very lucky to already have 24/7 eCPR capabilities. There's a lot of enthusiasm with the CVICU in order to get this built up as well. So everyone was on board. It just required somebody to, cross the T's and dot the I's and actually bring everyone together. I can't say that I did this all by myself. That's absolutely not the case. We also had an excellent EMS liaison, Kim Brackney, that was able to bring everyone together to this room, including all the EMS chiefs in our system. We're very fortunate to have several agencies bring patients to our hospital, which adds complications, but also provides a very diverse group patient population, but also diverse heads of agencies that can also provide some good feedback on to how we're doing. So we brought everyone together here. We went through each one of the criteria, explained how we were meeting or plan to meet each criteria. And at the end of it, each one of the EMS chiefs, along with the medical director of Dr. Katz, as well as myself, we all signed this attestation, which you can see on the bottom right there. And we continue to have quarterly meetings reviewing every single out-of-hospital cardiac arrest case, CPR data using our Zoll CPR data acquisition form that we have online, as well as making sure that we're continuing to meet all the criteria to maintain our Resuscitation Center of Excellence attestation.
Amazing. I know it's a lot of work. Can you just quickly touch on if you've noticed anything with how patients are being treated? When I say treated, meaning medics come in with a patient, is there a different feeling about how those patients are looked at now that you're a comprehensive center? Is there a different vibe when you guys are reviewing those cases? I'm trying to understand, how has it impacted the culture of the hospital is really what I'm asking.
Yeah, like any situation where you have eyes on your work, people are going to, do the right thing a little bit more frequently. So, certain cases where maybe they would have been pronounced immediately upon arrival, I'm seeing that happen a little bit less, people being worked on a little bit more if they arrive in say, PEA. Alternatively, we're seeing people more comfortable with terminating resuscitation in cases where, for example, they were in asystole for more than 20 minutes after being worked on. We have a termination of resuscitation protocol, which we had to make in order to become the center. And now people feel more comfortable terminating based on evidence rather than feelings. I think agencies bringing patients to our hospital appreciate that when they work on patients for 30 minutes out of hospital, for us to previously just say, okay, this is useless, and because the pupils are fixed and dilated. Now I think agencies are seeing that we're a little bit more evidence-based and more systematic in our approach.
Beautiful. Very nice. Very, very well said. So I wanted to open it up here. Yeah, and I'm going to toss it over to Ben and actually first let's pass it over to Melissa. So Melissa, you've been really at the head of the table here when it comes to hospitals who are calling, trying to get involved. Can you talk to us about the process that occurs in order to become a Resuscitation Center of Excellence, and what you're doing at the FAEMSMD to make it happen, just so people kind of understand all the moving pieces that are happening, and then we'll end with some lessons learned from the group.
Sure. I would say, to reiterate what the gentlemen have been speaking about today, a lot of the work happens between the hospitals and the EMS, the local EMS agencies. And what we're here to do, FAEMSMD and the Resuscitation Committee, is to help facilitate those conversations, to provide the resources for those discussions internally, to help make those connections if perhaps the hospital doesn't have the connections with the local EMS directors, medical directors, and chiefs. We're happy to serve in that capacity as well. Any questions for criteria and things like that, we'll connect you with the resuscitation chairs and try to get those answers if it's not clear in our frequently asked questions. But largely what we're wanting to do is drive the collaboration locally and then support that as we can in the administrative processes.
Okay, so just for like a practical example, Hospital A hears about this and says, my goodness, I want to keep getting those cardiac arrest patients. They look at the website, they call you. What do you tell them when they call you and they say, I want to become a primary center?
I would first ask them if they've submitted an interest form online. When you submit the online interest form, it generates an email to our entire FRCE team so that we all know that your facility is interested and at what designation. That gets us on the radar. I'll respond to that with an email, or if it's a phone call, providing the FRCE toolkit and all the information with some additional steps and how these resources can be used. Then again, we really focus on that local collaboration, meeting with the EMS medical directors and EMS chiefs and the key hospital departments to review the criteria and program materials. Then again, we would jump in to clarify any questions that are needed. Once they get to the point where the CEO and the departments and the EMS are all in agreement on the criteria, you sign the attestation, which you guys have shared the PDFs online. If you're not able to edit that with your hospital name, that's what I'm here for. You could then, once it's signed, you just submit that to us, to me, or to our new project coordinator that we have. We submit that to Dr. Batista for a review, and then we respond with your official certificate and the next steps to celebrate and making it known that you're a designated center.
Excellent. That's a great explanation. And there was one piece in there that I want to expand upon, because, as a local medical director, it's incumbent upon me and my team to get in the car. Hopefully there's coffee and donuts. We go to the hospital. We sit with the CEO and all the players. We explain to them what this is. I mean, I've given a number of these talks. Ben has, I know Carrie has, Dr. Ingram has, and especially Tom. And then we just slide the paper across and we say, here's our expectations. We'll come back in a few months once you've chewed on this. and we want you to sign this. That's how we're going to move ahead. And so it's a process. But thank you so much, Melissa. We have a few minutes remaining. Carrie, I'm going to have you spearhead this one. Lessons learned. You've been through a number of these. You're the one who approves these at the very end of the day. What are some of the most common questions that you're getting from hospitals when they see this come across their desk?
I think we touched on a few of these, but common questions we get are, what counts for education? What do we need to do for smoking cessation? Things like that. We don't specify that. We want them to start that program and do the outreach. What counts? I kind of touched on this. What counts for? Well, what does cardiology's involvement need to be? Cardiology, like I said, that is depending on you. You have a full in-house cardiology fellowship, then maybe you want cardiology to come to the bedside and do a consultation. Maybe you just want a phone call between the ER doctor. And then a lot of the other things are we get, does our cath lab need to function 24/7? And the answer to that is invariably yes. The goal of this is to have a sort of an end point to that patient's level of care, right? So everything should be available at that facility. So some of the other questions we get are, we have a satellite hospital. Does that count? And the answer to that would be no. This is going to be just like if you have a hospital that's a trauma center and you have a satellite hospital, that satellite hospital is not also a trauma center. The goal is to have it. It's what is in house. And then one of the other things that I've heard, well, we do all of this stuff. Well, great, get credit for it. Improve and collaborate with everybody. Brag about it. But again, like was discussed, I think what some of them said, we do all this stuff, but there's not. The goal is to bring consistency to it. The goal is to bring a level of care that's the same for everybody. And it doesn't. None of this, as you saw, none of this takes away from anybody's ability to make decisions on anything, any doctor's individuality. It doesn't take any away from that. But the goal is to sort of bring, hey, here's the level of care we're going to provide for these patients.
Excellent. Let me bring in Chief Moran. So, Chief, you've been the chief for many years. You were the person who spearheaded this whole thing many years ago. What is your take on this whole process here? And what words of wisdom can you give some of the people on the line who may be thinking about getting this done?
Just encouragement. I think, one, too much credit. I appreciate it, but thanks, Doc. But two, really it's about what is EMS used to? Unfortunately for many EMS systems, we bring the patient into the ER after doing high performance CPR and PIC crew and just trying to deliver the best care we can. And we'll see the team work the patient for 5 minutes and call the code. Great end-tidal CO2. We'll see PEA on the monitor. We've even had some horror stories of seeing a shockable rhythm on the monitor and the patient being called. Yeah. And we don't blame the ER teams for that. We understand the stress they're going through also, and staffing shortages and education challenges and everything else. But the reality is we all have to work together to improve the system of care. That's been the point of today's entire webinar. And if we can do that, where EMS is working and integrating and training together, practicing delivering patients to the ER, and the rest of the hospital system really saying, hey, we're going to work with you. We're going to deliver this standard of care across the board. Now patients survive. Now patients live to see another sunrise. I mean, that is the point of why we do this and passing on this education. So for me, I want to thank everybody for attending today. And thank you again for letting me have the chance to talk real quick.
Absolutely. And so I'm gonna have Ben end it for us. Ben, take us away here with the vision for Florida 10 years into the future. We have resuscitation centers. What does this look like when all the hospitals are official, all across the entire state, 190 something hospitals? What does that look for the state of Florida?
The way that I envision this really, from some aspects, could really be kind of a spoken axle kind of thing where, it's really an organized system statewide where we really have perfected the best practices and we make what works work in whichever region, because we're all different style EMS systems or different hospital systems. and primary are just as important as the comprehensive. And even, certain primaries, if it's a health system, the primaries can then feed into the comprehensive because you don't want to just spread everything out. And that's what I really see. I really see, everything, any actual hospital with an emergency department being either a primary or comprehensive. We can do it. There's no reason we can't.
Perfect. I love it. Well, with the number of cardiac arrests that the state of Florida sees every year, which is in the range of 11,000, if we could just move the needle a little bit and get 10, 20, 30, 100, 200 more people back to the table at Christmas time, wouldn't that be amazing? And I love that to see another sunrise. That's what we're all here to do. So to my colleagues who joined me today, for Dr. Ben Abo, Melissa Cahey, Dr. Carrie Batista, Dan Moran, and everyone from the state of Florida who couldn't be here, Tom DiBernardo, Ken Shepke, Steve McCoy, everyone at the state, we thank you all very much. And so this will be recorded and will be up on YouTube shortly. Any of my colleagues want to give any final words before we end?
I'd say just again, this is all about teamwork, and it doesn't matter whether you work for a fire department, private EMS agency, third-party EMS agency, the hospital, whatever. This is a team approach, and long gone should be the days of we do all that we can pre-hospital, and we drop them off, and we don't know what's going on.
Amen. Amen. Let's take that one to the bank. Perfect. All right, everybody. Thank you guys so much. Stay safe out there. Thanks for taking time out of your day to join us. And we appreciate you guys. Have a great one.
Thank you.
Yeah, Ben, stay safe wherever you're driving to. Through San Antonio. I don't know where you're driving. Be safe, my friend.